I'm Brian Rini. I'm a Ingram Professor of Medicine and Chief of Clinical Trials at Vanderbilt University. So risk stratification in kidney cancer historically was based on Memorial Sloan Kettering criteria, and I'm talking about advanced disease now, not in localized disease. And this was a prognostic system of 5 factors developed by Memorial from patients treated on, if I remember correctly, interferon-based clinical trials pretty much in the 1980s in Memorial. So it was a very sort of unique data set, but withstood the test of time in terms of things like performance status and the like. About 10 or so years ago, Danny Heng published what are now known as IMDC criteria, International Metastatic Database Consortium, which is now, probably dozens of hospitals and 20,000 patients. At the time of that initial publication, I believe it was around 600 or 700 patients with metastatic RCC who had been treated with VEGF targeted therapy and mostly sunitinib. And there were 6 factors that were identified as being adverse factors, and based on the number of adverse factors, patients were categorized into risk groups based on survival. And so what's important to note about that is these patients were entirely VEGF treated. So favorable risk patients who were deemed favorable because they lived a long time either had slow growing disease or had very VEGF responsive disease. And that's why, as we spoke about, favorable risk tends to respond to VEGF inhibitors. That's how it was defined. As you accumulate risk factors, your biology, a patient's tumor biology, goes away from angiogenesis, probably more towards an inflammatory biology, and frankly, probably more towards something else. Not everything in kidney cancer, of course, is inflammation or angiogenesis. There's probably other important pathways we haven't fully discovered and taken advantage of yet. So I use IMDC. I will say, I use it somewhat in my clinical practice, somewhat to prognosticate for patients. I don't use it as much in treatment selection, I think, as others do. But these are important simply because when we're looking across trials and looking at data sets, it helps us understand, who made up that particular cohort of patients. And was it all favorable or all poor or somewhere in between? And it just gives you a little bit of a level set in terms of looking across data sets, which of course we do all the time. So I think, we're all hoping for a day where we're not necessarily just using these clinical factors, but are using biologic-based factors. And I think we're closer than we were when I started doing this, but I'm not sure we're that close. I'm not sure we're close to what our friends in, say, lung cancer do with ALK and EGFR, or breast cancer with HER2, or I'm sure there's many other examples. We're just not to the point of having a biologic marker, be it DNA mutation, RNA expression, immunohistochemistry, or whatever, that will make me choose treatment A over treatment B. So we fall back on these clinical factors, which have utility, but I'm hoping, in the next era, the next wave of trials, so to speak, that we can develop true biologic markers to help us, make better choices for patients.